remind me to ask you to silence your cell phones. Thank you. Mike, we're ready and on? Okay, terrific. So good morning, everyone. My name is Brenda Mamber. I'm one of the members of the Chesed Education Committee.
I don't know if the microphone is working.
Microphone is not working.
It's hard to hear you, and I'm right in front of you.
Do we have a longer microphone?
We have to speak right into it? That's good. Okay. Good morning, everyone. My name is Brenda Mamber, and I am one of the committee members on the Chesed Education Committee here at Brotherhood. Welcome. We have a wonderful speaker and a great program this morning. Before we get started, I want to thank you for coming. I want to thank my fellow committee members from the Chesed Committee who worked over the last couple of years to bring annual programs to Brotherhood, and I trust that this one will be as interesting and thought-provoking as our past programs. I want to thank the synagogue and Phil, all of the synagogue staff, Rabbi Alder, Cantor Weiss, and of course our speaker today. So just to let you know, we're going to go to 12:30. At 12 o'clock, yes, Cantor Weiss, we're going to have a healing circle, so please stay after our keynote and sit with us and participate in a healing service. After Dr. Ofri speaks, she also, you noticed our table with books, and our books are for sale. And also there is a sign-up sheet if you'd like to be on her mailing list. Okay. So I'd like to introduce Rabbi Walter to welcome us.
It is one of the most important words in Judaism, and also one of the least understood. And its most famous occurrence is recited in the Shema Yisrael, Hear, O Israel, the Lord our God, the Lord is one. And the word is not Lord or God, but the word is Shema itself. It means so many things: to hear, to listen, to pay attention, to understand, to internalize, to respond. Time and again, in the last month of his life, Moses tells the people, Shema, listen, heed, pay attention. Hear what I am saying. Hear what God is saying, if you would only listen. Judaism is a religion of listening. This, teaches Rabbi Jonathan Sachs, is one of the most original contributions to civilization. The twin foundations on which Western culture was built were ancient Greece and ancient Israel. They could not have been more different. Greece was a profoundly visual culture. Its greatest achievement had to do with the eye, with seeing. It produced some of the greatest art, sculpture, and architecture the world has ever seen. Its most characteristic group events, theatrical performances, and the Olympic Games, were spectacles, performances that were watched. Plato thought of knowledge as a kind of depth vision, seeing beneath the surface of the true form of things. Now, Judaism offered a radical alternative. It is faith in a God we cannot see, a God who cannot be represented visually. The very act of making a graven image, a visual symbol, is a form of idolatry. They're both forbidden by the form of idolatry. God communicates in sounds, not sights. He speaks. God commands. God calls. That is why the supreme religious act is Shema. When God speaks, we listen. This may seem like a small difference, but it is in fact a huge one. For the Greeks, the ideal form of knowledge involved detachment. There is the one who sees, the subject, and there is the one who is seen, the object, and they belong to two different realms. A person who looks at a painting or a sculpture or a play or at the theater or at the Olympics is not himself or herself part of the art or the drama or the athletic competition. He or she is a spectator, not a participant. Speaking and listening, however, are not forms of detachment. They are forms of engagement. They create a relationship. We can enter into a relationship with God, even though God is infinite and we are finite, because we are linked by words. In Revelation, God speaks to us. In prayer, we speak to God. If you want to understand any relationship between husband and wife, or parent and child, or employer and employee, or patient and doctor, pay then close attention to how they speak and listen to one another. Listening, shmiat ha'ozen in Hebrew, lies at the very heart of a relationship. It means that we are open to the other, that we respect him or her, that their perceptions and feelings matter to us. We give them permission to be honest, even if this means making ourselves vulnerable in doing so. A good parent listens to their child. A good employer listens to his or her workers. And a good doctor listens to his or her patients, as we shall soon hear from Dr. Danielle Ofri. In Judaism, we believe that our relationship with God is an ongoing tutorial in our relationships with other people. How can we expect God to listen to us if we fail to listen to our spouse, our children, or those affected by our work? And how can we expect to encounter God if we have not learned to listen? On Mount Sinai, God taught Elijah the prophet that God was not in the whirlwind, the earthquake, or the fire, but in the kol dimama daka, in the still, small voice, that we can define as a voice that you can only hear if you are truly listening. Too big now?
So can you hear me? Yes? Okay. It's my pleasure to introduce Danielle Ofri, MD, PhD, who's a physician at Bellevue Hospital, the oldest public hospital in the country, an associate professor of medicine at NYU. Danielle writes about medicine and the doctor-patient connection for the New York Times and other publications. She's the editor-in-chief of the Bellevue Literary Review, the first literary journal to rise from a medical setting, and the author of 5 books about the world of medicine. And she's also a Brotherhood Synagogue congregant. So welcome. Okay, can you hear okay? The single biggest problem in communication is the illusion that it has taken place. In those words, the single biggest problem in communication is the illusion that it has taken place. And those words were supposed to have been spoken by George Bernard Shaw. And they might be apocryphal, but I think they encapsulate how most people feel about their medical encounters these days. And when I go around and talk in different places in the country, I think the biggest complaint that people say as patients is that my doctor doesn't listen. And that's partly how this book came to be. In fact, many of you know that about 6 years ago, we spent a year in Israel. And I spent that year, for me, was working on my book, What Doctors Feel, How Emotions Affect the Practice of Medicine. And in writing that book, I was hoping to do a chapter on doctors and patients as friends. And so I began to troll the internet looking for good examples of that. And I stumbled upon a blog of a doctor who was speaking about becoming Facebook friends with one of her patients. And so I called her. She's from Atlanta. And we had a great conversation. I'm sitting in my backyard in Zichron, and she's talking from her office in Atlanta. And she told me about this very challenging patient, a young woman with kind of a mysterious, difficult to diagnose illness, but fairly severe.
And the doctor and patient kept clashing on the direction of treatment. The patient kept pushing for more and more aggressive treatment to the point of things like bone marrow biopsies and chemotherapy agents. And the doctor was really nervous about these very toxic treatments, so kept kind of wanting to put the brakes on so as not to cause any harm by these toxic treatments. Anyway, in the weeks that followed, I'm reading more of this doctor's blog, and I noticed comments on the blog from someone who I think might be that patient. Even though I didn't know her name, she identified herself and her symptoms, and she used her full name. So I asked the doctor to ask the patient, and the patient said she'd be happy to talk. And so again, from my backyard in St. I called her, and we had an amazing conversation. And what fascinated me is that she told a completely different story from her doctor. And it wasn't as though one was right and one was wrong. They were just completely different. It was almost like, if you imagine a movie set, and there's two movie cameras that give a scene from a different angle, or at times it felt like it was two different movies altogether. And again, this wasn't because one person didn't have the details. The patient was very educated, very aware, and both doctor and patient were thoughtful, self-reflective, self-critical about their own shortcomings, yet even with that, they still had very different views of how things transpired. In fact, the patient said to me, it's like we're in a rowboat, we're each rowing in the opposite direction. And you may have had that experience with your encounters with the healthcare system. And so I thought that would be a great part in that book, but it didn't quite make it into the final cut. So I thought, okay, that'll be the topic for the next book. I'll find all these doctor-patient pairs, and I'll interview them and sort of show things from both sides. But unfortunately, it turned out to be harder than I thought, because if things go well between doctor and patient, there's nothing much interesting to write about. But if things don't go well, usually one person doesn't want to talk. So in fact, it turned out to be quite a bit harder to find doctor-patient pair. So I found a few, and this particular doctor-patient pair became the focus of the book. But I began looking more into the area of communication and research about the science of how we communicate or how we don't communicate. But I want to start by sharing with you one of my own patients, and the names have been changed. It was late on a Thursday evening when my office phone rang. It was Omar Amadou. I am not feeling well, he said. I need to see you, Dr. Ofri. The clinic was closing up. I'd already turned off the computer and about to turn off the light. I need to see you now, Mr. Amadou said. The annoyance in his voice was apparent even with his thick West African accent. In the few months that I'd known Mr. Amadou, I'd probably fielded maybe 50 phone calls from him. He always had something bothering him. He needed a form filled out or a prescription renewed. He always needed it right away. He was always showing up at the clinic without an appointment, expecting to be seen right away. But he also had a severe heart condition, even though he was only 43. At our first visit, he hauled out a tome of papers from a cardiologist in Pittsburgh that detailed a severely malfunctioning heart, one that required a pacemaker, a defibrillator, and several stays in the ICU. So when he called on a Thursday evening, I took his concern seriously, despite the irritating tone of his voice and my depleted reserve of patience for him. I questioned him about symptoms of congestive heart failure or arrhythmia, things that would send him right to the ER. But he had no specific symptoms, just a vague sense of not feeling well. I wasn't scheduled to be in the clinic the following day, Friday, but because of his poor heart, I didn't feel comfortable having him wait until Monday. Please come to the clinic tomorrow, I told him. I explained that I wouldn't be there, but my colleagues will be there at the urgent care section. When I arrived on Monday, there was an indignant voicemail from Mr. Amadou. I come Friday, but you not there, so I go home. I need to see you. Either he didn't understand what I said, he was simply being stubborn. The next 3 days were a series of missed phone messages between us. If he didn't feel too bad, I would tell him on this voicemail, then we'll give him a regular appointment, in a couple of weeks, and if he felt sick, though, he should come to urgent care. He left me a voicemail saying, I need to see you, Dr. Ofri, seeming not to acknowledge any of my messages toward him. Midday on the following Thursday, just as I was saying goodbye to the last of my morning patients, Mr. Amadou popped into my line of sight. Tall and lanky, dressed in a powder blue tracksuit, he signaled anxiously at me. I need to see you, Dr. Ofri, he called out. It's very important. I was unprepared for the rush of anger that flooded me. Mr. Amadou would just walk in the door, expect I'll drop everything and give him a medical exam right away. Yeah, he had a bad heart and everything, but that didn't give him a free pass to be so demanding. Obviously, whatever was bothering him couldn't be so bad, given that he'd chosen to spend the week trading messages with me rather than coming into the urgent care clinic. I need to draw a line. Mr. Amadou, I said, you cannot just show up to the clinic without an appointment. I had come here to see you, Dr. Ofri, he said. Yes, I know, I said, but you other patients have scheduled appointments. There's something urgent, you go to urgent care today, otherwise you need to make an appointment like everyone else. I knew that if I gave Mr. Amadou a medical visit right now, I'd reinforce the idea that he could just walk in any time and get an appointment. He'd be at my doorstep every week. But I also understood the severity of his cardiomyopathy. This was not the kind of patient I could take a chance on, annoying or not. Okay, Mr. Amadou, I said, just a quick visit, but next time you have to have an appointment. Mr. Amadou smiled broadly. He had now figured out how to get an instant appointment. I knew I was going to regret this decision. He would just be annoying and persistent until I caved. The medical assistant was about to leave for lunch, but I gave him a beseeching smile. Could you please do a quick set of vital signs for Mr. Amadou? He hesitated, raised an eyebrow, and then finally assented. With relief, I gestured Mr. Amadou into the assistant's room. Mr. Amadou took 2 steps, and then paused in mid-footfall. He seemed to hold his lanky body aloft, almost as though the muscles were debating whether to move it forward or to move it back. But it was all an illusion, as he collapsed to the floor with a heart-stopping thud. I dropped to my knees and pressed my fingers to his neck to check the pulse. Mr. Amadou, I shouted, can you hear me? He was breathing rapidly, slumped against the door frame, his legs stretched out to the hallway. He placed his right hand over his heart and said, my heart. And I was swamped with a horrific wave of guilt. I called for oxygen in a stretcher while I crammed my stethoscope underneath the jacket of his tracksuit. His pulse was 130. His fingers were so cold that the oxygen saturation monitor couldn't pick up a reading. We loaded his listless body onto the stretcher and began wheeling him rapidly to the ER. Disconsolate, I held Mr. Amadou's hand as we pressed down the hall, striding briskly to keep my pangs of remorse at bay. We rolled him into the triage bay and explained to the ER doc what had transpired. As we finished the handover of medical care, I turned back to Mr. Amadou and took his cold, clammy hand in my 2 hands and gave it a squeeze. His fingers were rigid. His fingers were frigid, and they were rigid. I apologized for berating him in the waiting room and for all of our miscommunications during the week. He opened his eyes to my words, but was too breathless to speak. He nodded slightly and then squeezed my hand weakly. I trudged back to the clinic, staring down at the linoleum floor the whole way. I couldn't hold back from dissecting what had just transpired, trying to figure out the mistakes. Mr. Amadou had been demanding, probably unreasonably so, and I put my foot down, perhaps a bit too decisively. But maybe the problem was more basic than that. Maybe we just weren't hearing each other. So as I mentioned, I became intrigued in the science of communication, how we speak to each other. And it has a very intriguing history. So the field of communication didn't start in academia. In fact, it started in the field of public speaking. And it originated from a group of frustrated English teachers who were upset at how poorly their students and proteges communicated. And the idea was that when people spoke, like I'm speaking to you now, the speaker had something to say and would pack the information to a little envelope, put it in a basket, send it down a zip line to you in the back row, and you would unpack it when you got it, and that was the information. So the onus on the speaker to make that information easy to understand. And so if the listener in the back row didn't get it, maybe it's because the speaker wasn't clear enough, wasn't articulate enough, or smart enough, or loud enough, and the whole emphasis was on the speaker. And if you think about the doctor and the patient, when the patient's talking and the doctor doesn't get it, you say, well, the patient, they were a poor historian. Right? That's the term that medical personnel use. And whenever my students say that, I'm like, think they make a better social worker or an architect? You know, they were not made up to be a historian. They don't get the joke. But we blame the patient's history skills for the doctor not getting. We never think about our work in the listening part. And I became intrigued by some research done by Janet Vivelis, a researcher in British Columbia. And she did a very ingenious experiment. She took a bunch of college student volunteers and paired them up. And one person had to tell a dramatic personal story, a near miss. I almost fell off the cliff, or the bus almost ran me down. And the listener had to listen. But the listeners had one of 2 tasks to do at the same time. So one group of listeners were told, while your friend's telling the story, I want you, in your head, to figure out how many holidays, how many no school days between now and Christmas? And it was February. So as the person speaking, the other person thinking, okay, there's Labor Day, Memorial Day, Groundhog Day, is that a no school day? While the person's listening, while the other person's speaking. The second group of listeners, they had to press a button every time the listener used a word starting with the letter T. So these listeners were a bit distracted. And when she watched the speakers, with the holiday counters, they were terrible listeners, as you can imagine, right? They're, the speakers talking about how they, the buffalo almost poured them, and you're thinking, okay, is Canadian Thanksgiving the same day as American Thanksgiving? Right. So they didn't even nod or say at the right times. So they had no generic signs of listening, which is just letting someone know that you're tuned in. And they had zero specific responses, like to the actual content. They didn't at the right time or anything like that. And we know those speakers, right? They're the ones who talk to them, they're on their phone, they're thinking about the NCAA basketball game, they're thinking, will the cafeteria still have minestrone soup when I get there? And they're really not focusing very well. Now, the other set of listeners, the T-word counters, now these folks had to listen carefully to catch those T-words. And they nodded and said, all at the right times. They kind of got the generic listening. But they were equally bad at the specific responses, right? They didn't catch the high point of the story. So they were listening very attentively, but they weren't hearing. And that's a bit about how I think about how we doctors often are. But what was really fascinating was the effect on the speaker. Remember, these are dramatic, near miss, almost killed myself kind of stories. And when the speakers are distracted, when the listeners are distracted, the speaker does really poorly. They start to falter. They circle around, tell the story again, get the climax again, or they get to the dramatic part, and then they kind of just sort of fade away because the person isn't listening. To me, the most intriguing part was the difference between the two kinds of listeners. The people who had the most profound, unsettling effect on the speaker were the T-word counters. And I think it's because the holiday counters, they look checked out. We already know, oh my God, they're a lost cause, forget about it. But the T-word counters were tricky because they looked like they were paying attention. They were focused on every word, but they weren't hearing the content. And that discombobulated the speakers. And so Bavelis termed the listener as the co-narrator. The person who listens helps shape the narrative. I was just asked last week to do like a video presentation with a group of doctors, and I've done it a few times, and I hate them. And this research demonstrated to me why I don't like them, because without the audience, without the eye contact, the nodding, hopefully laughing occasionally, and not falling asleep, it's very hard to speak without the sense that the person is listening. And so when I think about the patients telling their story, which is often a dramatic near-miss story, or I'm worried about living or dying, and the listener, the physician or the nurse, how we listen affects the quality of the story. It also affects the ability of the patient to tell the story as accurately as possible. And if you think about it, when you go to the doctor's office, the story is the most important part, right? That's the primary data, especially in non-procedural based fields. The patient says what's going on, and we have to make that story as accurate as possible. The Greek philosopher Epictetus was supposed to have said, we have 2 ears and 1 mouth so that we can listen twice as much as we speak. Epictetus clearly was not a doctor in 21st century America, right? He was not sitting there with EMR typing in while their patient's speaking or trying to answer phones and pagers at the same time. And some of you may know the data. How long does it take for a doctor to cut off a patient when they begin speaking? It's about 10 seconds, right? Doctor, my stomach hurts. Oh, when did it start? When did it end? We come right in. And not to be rude, I think we're really trying to get at the heart of it. We have this sort of hound dog instinct to get on there and answer those questions. The problem is, if the patient had a second thing to say, like, I'm actually dying of cancer at the same time, we'll never get to that because we've already chased down this first thing. We've diverted them into the path that we want to go on. And you can see how poor listening skills and poor communication skills can add to misdiagnosis, right? We never get to the second thing or never flesh out the first thing with what the patient really has to say. So typically when a patient comes in, the doctor says, how can I help you? And they give their, what we call a chief complaint. Think about it, we already call it a complaint, right? Not a concern or anything, it's a complaint, they're a complainer. So I've often wondered, what would happen if we doctors did not cut off our patients, right? So I asked my colleagues, like, oh my God, they talk forever, I said, how long? 5 minutes, 10 minutes, 20 minutes. Not the Puerto Ricans, they were talking for an hour. And so I thought, okay, there's got to be research out on this. So I found one study done in Switzerland where the doctors just said, what can I do for you? And they just say a word and set a stopwatch. You know how long the patient spoke for? 92 seconds. Right? Not the tsunami that we fear. The patients would simply flood us with stuff. They stopped after a minute and a half. But you know the Swiss, reserved, precise, diplomatic, right? They don't have the American gene for loquacious gabs. I thought, okay, I'm going to try this here. So the very next day in clinic, I thought, I'm going to do this. So each time a patient started what they have to say, I clicked on my stopwatch and didn't say a word other than anything else. So first patient was like 38 seconds. They were amazing, but they just had like back, they were healthy, right? The next patient with a little bit of back pain, some upset stomach, they were, a minute and a half. Then I had a couple patients, with their, cholesterol going up, their waistlines going up, their blood pressure, and that, maybe took close to 2 minutes. But then came the kicker, Josefina Garza. I was going to share with you with Ms. Garza. Ms. Garza is from Argentina. Okay. Ms. Garza was a teacher in her native Argentina. Ms. Garza was saddled with a vast array of insoluble pains, compounded by anxiety, depression, and irritable bowel syndrome, plus a demanding mother to care for. Exactly the kind of patient who can drown you with a list of complaints. I love her droll observations about New York City's pretensions of culture, which of course could never measure up to the sophistication and elegance of Buenos Aires. But if I let her talk uninterrupted, this visit would unfurl like a Borges labyrinth. I'd hear a dizzying list of symptoms from every organ in her body, plus a rundown of her mother's medical ills, plus a stinging critique of Metropolitan Opera's soulless production of Turandot. I'd be forced into explaining the decisions of her mother's doctors as well as the artistic director of the Met. Both of us would be in a sour mood by the end, and the whole thing would turn out to be a sprawling, onerous mess, worthy of an atonal Schoenberg opera, which Miss Garza, of course, would excoriate on philosophical grounds. But I promised myself I'd let every single patient talk today. If I eliminated the, quote, difficult patients from my evaluation, then my data, however informal, would be flawed. I girded myself for battle. Asked Ms. Garza, how can I help you today, and reluctantly clicked on the stopwatch. Every single thing hurts, she said, from my toes to my head. There were shooting pains in her gums. Neck pain was radiating down her spine. Her mother had insomnia and kept her up all hours of the night complaining. Each time she paused, I asked gamely, anything else? And there always was. I'm only 45, she said, but I feel like I'm 85. Every step hurts. I feel like I'm walking through molasses. My head feels like it's swollen to 5 times its size. I scribbled a few notes on paper as she spoke, but tried to maintain eye contact the whole time. Let's get everything out on the table, I said bracingly. Every last symptom, and then we'll figure out where to go from there. I let her keep talking until she had fully, truly, absolutely come to the end of all she had to say. In the dip of silence that followed, I reached over to click off my stopwatch. I'd estimated 10 minutes, 12 minutes, but in fact it read 4 minutes and 7 seconds. And the Met had come out unscathed. I turned back to Miss Garza and said, is this everything? She nodded and I showed her the list. It was, when viewed on the page, it actually didn't seem to overwhelming. It was long, but it was finite. Ms. Garza already had the $1 million workup, which was all negative. So I explained to her that she had something going on. Medicine, I said, is very poor at explaining pain symptoms, but that doesn't mean we can't go ahead and try to treat the symptoms. We went down the list, trying to identify which pain might be helped with ice, which with heat or massage, which with physical therapy, which with pain medications. We talked about seeing a therapist to decrease her stress, and how she might get help in caring for her mother. We talked about exercise, and we wrote up a plan. At the end of the visit, which didn't go over by too much, she said something that I'd read about, but never heard a patient legitimately say. She said, just talking about this has actually made me feel better. I wanted to jump up and sing an aria, which luckily all parties involved I refrained from. But I was in the process of realizing something else. Just talking about it had made me feel better.
Right.
Like any patient honest enough to admit, we hate patients like Ms. Garza. They have a million things, we can't solve them, and we worry at any pause in the conversation, something else is going to come out, one other unsolvable problem. And so we rush to turn off the spigot as expeditiously as possible, shut them up before more things come up that I can't do anything about. And I think for patients like Ms. Garza, they're used to having walls erected around them, to having doctors shut them up as quickly as possible because we're so worried about surprise things at the very last minute. And so it then makes them, I think, paradoxically, more anxious to pull things out, keep pushing things, which is why they may come across as, quote, difficult patients. And you know, giving her the chance, I think this might be the first time that she ever said every last thing that she had on her mind. And now, maybe there was something physiologic, maybe her adrenaline level went down, or her cortisol level, maybe her endorphin level was up, or maybe it was a sense that she didn't have to worry about cramming everything in because she had, at least on the surface, all the time in the world. And our subsequent visits were much easier because it was all out. We got all at once, and the list didn't keep getting bigger. We'd gotten the entire, whatever 50 things they were, down once. And each time was adjusting things, maybe adding one thing. But it eased the tension in the visit. And so when my students and house staff talk about not having enough time, I bring this up as one mode of efficiency, right? Letting the patient talk uninterrupted is actually efficient because it made subsequent visits easier. It made the stress level go down. It made my fear of some other surprise, a last-minute plot twist, much lower. So I want to shift a little bit about the, in fact, power of what we say. So as physicians, most of us describe what we call evidence-based medicine. That is, if I prescribe a medication for you or a chemotherapy, that there's some evidence behind what we do, and that's important because there's lots of things that we've done in the past that didn't have evidence. So I've wondered about the evidence about how we speak. Can the words we say have an effect on medical outcomes? There was a seminal study that really started the field way back in 1964. And they took 100 patients going for surgery the next day, abdominal surgery. If you've ever had abdominal surgery, or know someone who's had, you know that post-op pain is a misery. And we often treat that with strong narcotics or opioid-like medications because you need something strong. But of course, those medications have a huge list of side effects, right? Nausea, vomiting, constipation, addiction, respiratory arrest, and death. So the interest in lowering the amount of narcotics needed in treatment is strong on all sides of the healthcare game. So in this study, the night before surgery, the anesthetist goes to each patient the night before to talk about the surgery. But for a random half of the patients, the anesthetist added in a 20-minute discussion about post-op pain. Very basic, what it is, what causes it, how muscles clenching really kind of cause the pain, when to expect it, what it would feel like, where it would be on your body, techniques for relaxing the muscles to try and minimize the pain. If that didn't work, how to call the nurse, what the nurse might bring, what the medications are available, what the side effects are. That's it. The next day the surgeons operated. The surgeons had no idea who got the extra conversation. The surgeons took care of the patients afterward. Now, it's no surprise, I think, from our vantage point, in 2017, that the patients with the extra discussion had less pain. But it's the magnitude that's really amazing. Those patients with a 20-minute discussion needed half the amount of narcotic pain medications. 50% reduction. As an internist, anything that minimizes constipation, gold medal in my book. But even more amazing is that they were discharged from the hospital 3 days earlier. Now think about that just from a cost perspective. Each day in the hospital, $5,000, $10,000. So the savings of close to $15,000 or $20,000 from a 20-minute discussion. Quite cost effective, as we look at things. But also, think about all the hospital complications that could be avoided, right? Infections, rashes, falls, drug interactions, adverse events, urinary infections, things that we give our patients by being in the hospital. So the benefits were enormous. So this study really set the field on fire, and there's been a lot of research about how our communication skills can have really hard medical outcomes, not just touchy-feely, oh, I feel better, but actually that the outcomes are in fact better. And one of my favorite studies involves back pain. And as you know, back pain is very prevalent, and honestly, if I look back at my medical career to this day, if there's been a day without back pain in my professional life, I cannot recall a single one. Everyone comes in with back pain, plus friends and family too. So the treatment of choice is physical therapy, and so I refer my patients to physical therapy. And I think about physical therapy in terms of the exercises the physical therapist will teach, maybe the massage or ultrasound. Sometimes they do electrical stimulation to help relax the muscles. But I don't think in terms of how the physical therapists speak to the patients. So a Canadian study decided to look at that. And they took a bunch of patients with back pain and sent to physical therapists. And in this study, they're all getting the electrical stimulation, this fancy little machine. So they divided the patients in half. Half got the machine turned on, half got the sham treatment. That is, the machine's all set up and nothing happens. They said, oh, this new machine's really quiet. Now, what's amazing is the people with the sham machine with nothing had a 25% reduction in their pain relief. Right? Nothing at all, just a fancy machine, put the things on, and nothing, pain relief by a quarter. That's pretty good, right? But the machine did better. Those patients got a 45% reduction in pain. Then they further subdivided the physical therapists. Half the physical therapists were told to remain silent, right? Everything's got to be quiet during the treatment. And the other half were coached to be engaged, to ask about the patient's pain, how it's affecting their life, to be optimistic that they get better, to be empathetic and compassionate. And that's it. Now the patients who had the engaged physical therapist but the fake machine, they had a 55% reduction in pain. Remember, the machine gave a 45% reduction. So the words alone were more powerful than this, $20,000 machine. Now the patients who got both, the machine being on and the engaged physical therapist, had a 75% reduction in pain. So it was additive. But to think about just the words we use themselves can have a potency comparable to fancy machines and expensive side effect-laden medication is pretty amazing. Now, this doesn't come as any surprise to people who study the history of medicine, right? Before we had medications that actually worked, like antihypertensives, antibiotics, and organ transplants, and other treatments, the way we communicated, that was kind of what we had, right? Shamans, healers, witch doctors for millennia know the power of the words we say, the connection we make. And a lot of this may be placebo, but again, if it works, maybe that's fine. A patient once said to me, I don't care if it's a freaking dill pickle. If it gets rid of my pain, I will take it. I'm going to share with you a story from my residency time. So I trained at Bellevue during the height of the AIDS epidemic in the late 80s, early 90s, and those of you remember that time, it was a fairly bleak, intense time where patients were very, very sick. So we had a ward in Bellevue, 17 West, the AIDS ward, and I'll tell you, I think the sum total T-cell count in the entire ward had been like 26. People were really, really sick, and it was really busy. We had a dying ward on the 12th floor. People were really end stage. It was a very bleak time, but incredibly busy. And this one particular night on call, the patient just kept coming in. The patient gets discharged, the bed gets filled in a minute because there's a line 20 stretchers long. But even the AIDS ward, even 17 West, quiets down eventually, sometime around midnight. Except that is for the howler. And the howler was this patient in his mid-30s who got his nickname from his nightly bouts of yowling at the top of his lungs. We'd been working this guy up for pain, top to bottom. We couldn't find any reason for his pain. He was already getting, heavy dose pain medications. And he was driving the place crazy. The patients couldn't get a night of sleep. And the nurses were at their wits' end. The doctors, we have patients in all wards of the hospital, so we got to come and go, but the nurses were tied down to the ward. So when this guy yowled all night, they could not escape. And so one night, 3 o'clock in the morning, the head nurse stopped the patient and says, you have got to do something, because someone's going to strangle that patient, and it could be me. So I go to this guy's room. It's like the 4th time that night. I've been on my feet for how many hours, I don't even know. I'm sick of him, he's sick of me. And I've tried everything at this point. It's like I'm rummaging my pockets for what I've got, and I find this little bottle of saline. So in a whim, I pull out a syringe from another pocket, and I pull out the saline. And I go up to the guy, and he's, moaning in his sheets and twisting around. I kind of feel sympathetic, but I'm so aggravated and so tired that I really can't muster a lot of compassion at this point. Plus, his moans are burrowing into my brain, deflating the last 3 functioning neurons that I had. So I pull out this syringe of saline, and I go up to him and say, you know about Tylenol, right? You've heard of Tylenol number 3, the kind with codeine? There's even a Tylenol number 4. And I hold up the syringe so it glistens in the fluorescent light. And I go right up to his face and say, but this, and here I pause for dramatic effect, this is Tylenol number 5. He gives me an interested look. And then he lowers his pajamas, and I give him a shot in the butt, and that's it. And then I pull up a chair and sit down, and I wait. He waits. And after about 5-10 minutes, I get him to leave. He puts his head in the pillow and goes to sleep. So I know from my perspective now that that was actually a no-no, because I deceived the patient. I was not honest about what was in the syringe. On the other hand, he got his first night of sleep in weeks. So nothing on the other patients, and of course the nursing staff. I mean, that head nurse was my best friend for the rest of residency. She bought me a bagel the next day, and we were really stayed buddies. And I ended up telling this story. Ted Kapchuk runs the placebo study at Harvard. And when I told him the story, he's like, yeah, well, everyone sort of has their moment, kind of like at 3 o'clock in the morning, where they sort of break down. But he's done some interesting work about placebo, how it can be very effective, even open label. He did a trial where he took patients with irritable bowel syndrome, and he said, here you go, this is a placebo. There is nothing in this pill. But I will tell you that research shows that placebos can relieve pain. And 30% of patients felt better afterward. So is that unethical? I don't know. I mean, we think about placebo in terms of clinical trials. Well, absolutely we need placebo for clinical trials, but in actual practice, we think it's a little shady, maybe it's not ethical. But honestly, if it's giving patients relief without taking away from another important medication, I think it's actually an important thing to do. And so I've changed my clinical practice based on these studies. And it comes up a lot with the lowly multivitamin. So if my patients always come and say to me, Dr. Ofri, will I get more energy if I take a multivitamin? I get it all the time. In the past, I always said, no, it's ridiculous, right? There's nothing in that vitamin. If you don't have a vitamin deficiency, vitamins do nothing but, lightening your wallet. Plus, there's no evidence on that. Now, I respond differently. I say something like, a lot of my patients feel like they have more energy after they take a vitamin. It's not a lie, because lots of my patients just say that. And all we learned is there's always a chunk of patients who come back, they feel better after taking that multivitamin pill from Dwayne Reed. So is it unethical? I don't know. I start to think that if it's not replacing another necessary medication, it would be unethical not to try, because our goal is to make our patients feel better. So it's a little bit changed how I've done my practice. So in summary, as I've done the research for this book and talked to all these people, doctors, patients, researchers, I've concluded that the doctor-patient conversation is the single most powerful tool in medicine. It's clearly the most powerful diagnostic tool, right? I know we all think it's not treatment. We've gotten a ton of blood tests, an MRI, a CAT scan, a radiology procedure, some tube in some orifice. But actually, most of the diagnosis can be made on just the story the patient tells the doctor, which is why I want both doctors and patients to recognize this critical piece and to give it its due. It's not just sort of an affable bedside manner that some nice, kindly doctors have, but really the critical data of medicine, and that making the story told, transmitted, and heard as accurately as possible has a lot of importance for accurate diagnosis, avoiding errors, misdiagnosis, and avoiding lawsuits. If you look at the data in lawsuits, rarely are they about actual malpractice and malfeasance. They're almost all about communication. The patient didn't get the information, they were out of the loop, the doctor wasn't honest with them, and usually the suits are frustrations and ways to try and get what they couldn't get from the regular interaction. But I also believe that the doctor-patient conversation is an important therapeutic tool, that it helps patients feel better. And again, not instead of their antibiotic, but in addition to, like with the physical therapy study, that giving the treatment and effective communication makes the patient's pain improve even more. Let's use that. So I'm just going to close with the ending of Mr. Amadou's story, in case you want to know what happened. When I think back to my communication mishaps with Omar Amadou, I can see more clearly how and why it was so exasperating. The geometry of our conversation went awry as we pursued divergent dialogues. Although I appreciated the severity of his disease, I was irritated by the muscularity of his insistence, and I quickly pegged him as a, quote, difficult patient. My labeling of him distorted what I heard. In his persistent demands for my time, I discerned entitlement. I became resentful. Had I stopped arguing about appointments and phone calls, I might have been able to intuit the animating impulse of his desperation. Those of us whose luck has kept us from facing down death can't really appreciate the exquisite vulnerability that serious disease engenders. Raw fear is a motivating force like no other. When I tried to imagine being Mr. Amadou, navigating an unforgiving medical system, negotiating in a foreign language, all with a heart that was flagging long before its warranty was up, I can begin to understand his approach. Why wouldn't he insist on what he perceived as necessary? Why wouldn't he refuse to take no for an answer? But I wasn't able to fully comprehend that until his body crumpled in my office and I felt the life wicking away from him. After his faulty pacemaker was replaced and the excess fluid drained from his lungs, Mr. Amadou came for a post-discharge appointment. It was an almost intolerable relief to see his lanky frame and his trusty tracksuit filling my doorway. When I shook his hand, the hand that had been frigid the last time I held it, I basked in its ardent warmth. I had no illusions, of course, and neither did he. The recent tune-up did not impart any fairy dust of additional cardiac reserve. Mr. Amadou would not be doing the 200-meter dash down Lexington Avenue anytime soon. But we dodged the bullet, this time at least, and we both exhaled cautious sighs of relief. Mr. Amadou's first question, of course, was when our next appointment would be. Normally, this would irritate me. But now his voice unfurled almost like a benediction. I couldn't promise that we'd never have any miscommunications in the future, or that we wouldn't get aggravated when things didn't work out. But I could promise that I would pay more attention to how I listened and how I spoke. One of my favorite poets, John Stone, was a cardiologist and poet at Emory University, and he wrote a poem called Gaudiamus Igitur for a graduating medical school class. And he wrote to his students, "You will learn to see most acutely out of the corner of your eye, to hear best with your inner ear." I'll just say that again. You will learn to see most acutely out of the corner of your eye, to hear best with your inner ear. A more astute lesson in communication I could not imagine. Thank you so much. Happy to take a few questions, and yeah.
Better communication is wonderful, but what's going on now in hospitals is in opposition to that, which is doctors need to stand at a computer, supposedly listening and typing away, and I don't think they can do both functions.
Right, so the question is about multitasking. And of course, if you look at a doctor's office now, it's like 1950s secretarial people all hunched over typing, and it is really hard to listen. And of course, multitasking is a fallacy. We can't do two things at once. We simply zip back and forth between them, and we lose accuracy along the way. So, but it's a reality. And I think the electronic medical record, the EMR, is quite the taskmaster. So how do we deal with that? So when I talk to my students and house staff about that, I talk to them about, if you take the first minute of the visit and just listen without writing, without looking at the computer, a minute of being listened to, called full frontal listening, right? That's very powerful. I think we're not used to that these days. We're so used to people either on their phones or having another agenda. We forget what it's like to be listened to very clearly. And then I'll say, I don't want to miss what you're saying. Do you mind if I write, take notes while you speak so I can get it all down? Then at least I've acknowledged the computer. It's a necessary evil. We all know it's there. But if I can let the patient speak for a full minute uninterrupted, I think we get the gist of the important things that are there. We've also made an investment in listening. But you're right, it's very hard. And of course, the electronic medical record, it's like you have to keep feeding the beast. So each time there's a new mandate, just make another required field, another required field. I mean, to finish a visit, for me, I have to answer, besides the patient stuff, questions about, patient smokes, have a colonoscopy, mammogram, if they domestic violence, educational challenges, language, asthma action plan, HIV testing, depression, satisfaction goals. I mean, at some point it becomes a little ridiculous. And do I think the ophthalmologist really asks about domestic violence every time? No, but they have to check the box, so they do it in order to close the visit. So I think we have to think a little bit about what we want out of our medical visits, and if we're looking for accuracy and efficiency, we may have to sort of tone down the EMR. Now, of course, some places are working with scribes who do the writing, so doctors don't have to write. I think there's some potential there. Thanks for that question. Yes?
So I want to commend you. I'm a physician, and I always love listening to everything you say.
And an ophthalmologist, I'm sure you asked about domestic violence.
And I think you should be talking to medical students, not lay people, because lay people appreciate, I know you do, and your book should be given to every medical student before they graduate, because maybe they will be better doctors. I do work with a scribe also, and what I have found is that in my practice, so I have an assistant take the chief complaint. And it's fascinating when the patient gets into the room and I say, so what brought you here? Which is what I taught my assistants. Completely different. The chief complaint that they write on their chart is completely different than what the patient says to me, which is amazing. Were we in, is it the same people? So I think patients do speak to the doctor directly, different than they speak to their ancillary staff. And unfortunately, all of us have to use ancillary staff in order to get through the massive amount of stuff we have to get through in a day.
Well, you're lucky to have ancillary staff.
No, I mean, well, I choose to do that because I'm in private practice. Wonderful.
Thank you so much. Yeah.
My question is, as patients, what can we do? All the stuff that you have talked about has been targeted. We as doctors can do this differently. We can change the EMR or whatever. But as patients, is there something that we can do to facilitate?
Yeah, thanks for that question. So if I have longer to speak, I'll talk about the patient side too. So I think for the patients to recognize, I think that the doctor-patient conversation is the most important part of the visit. But I think, again, patients have an expectation. It's not a medical visit until I've had 20 blood tests, an executive profile, until I've gotten the antibiotic prescription, until I've gotten an MRI, until I've gotten a referral, to a pulmonologist and a cardiologist, because that's what makes it medical treatment. But in fact, that's all the, side stuff. That's the ancillary stuff. That the medical visit is a doctor-patient conversation. And so to give it its due, so in fact, think about that conversation, and you might want to give it some forethought. Now, there's always advice, write down your questions, but I have patients come in over the list of 50 questions. So to also be realistic, that if you have 50 questions, it's all going to be superficial. So to pick one or two important things and make sure you get those across. And maybe you want to think about how you want to say this. In the book, I profile a chief listening officer in Holland. It was amazing, a job of just listening in a hospital. But what she does now as a consultant is she helps, and these are oncology patients who often have very long, complicated histories, how to craft a 3-minute narrative. How to get a story with the crucial things that are included, avoid things that are unnecessary, but hone that so you can make an efficient story, recognizing you don't have unlimited time. So I think about what you want to say, the one or two most important things, and know that this is the most important thing. If your doctor is not letting you speak, you have to stop and say, I need to tell you the story. Say, I'll be brief, give me 1 minute. And if they don't respond to that, say, listen, if you let me talk for a minute, you'll make fewer errors, and maybe I won't sue you.
We don't say that.
Isn't what But your doctor is not able to listen, then you need a different doctor. I think in the end, we used to talk about, so-and-so, great doctor allows a bedside manner. And I think we recognize that those are, it's impossible, right? You can't be a good doctor and be a lousy communicator because it's the essence of medical care. And luckily there are enough doctors out there that if your doctor really is adult and cannot really listen, then you just have to find someone else. Yeah.
Thank you. I really want to speak from the patient's point of view. I'll try and make it short. I have a tendency to go on, and in fact my doctors with that as well. I think as a patient, we have to look for a doctor with a fine-tooth comb, and I've done that all my life. I had my son because of that when everybody said I could not have a baby 40 years ago. I had 2 knees replaced, and I had very good doctors. But since I don't know about the specifics of the Obamacare or whatever, but I feel that the doctors, 90% of my terrific doctors even, are totally frustrated with what's going on with the healthcare. And so I feel that they don't listen to me carefully, and they immediately prescribe some medication, have drawers full of medication that I don't use because I don't need them. Even yesterday I looked at something, it was something for diabetes. when I need something to control the appetite or something.
Yeah.
I mean, they just prescribe something,
Right.
write it down, and even the doctors that I like a lot.
Right.
So I, as a patient,
well, let me respond to that. So I think that's again, even doctors feel like it's not